Hello and welcome to the Demonstrating Implementation Excellence stream of the SNOMED CT Expo 2020. My name is Susie Roy, and I'm the Customer Support Lead for the Americas at SNOMED International. And today I'll be moderating this session. Please use the Q&A box to type in your questions to the presenter. All questions will be answered at the end of the presentation. I am now pleased to introduce Monica Jones, the Chief Data Officer for DataCan. She is the Associate Director of the Health Data Research UK, and she is the Executive Lead of the Population Health Management at NHS England. And with that, Monica will be presenting Sailing the High Seas in a Data Ark. Okay, Monica.
Thanks very much, Susie, and thanks everybody for joining this session. So over the next 20 minutes, I'm essentially going to cover the use of open standards to tackle population health management challenge. The learning objectives from this session are threefold. There will be to help organizations to combine data and determine the value it can provide to enable better data-driven decisions. It'll also help people on how to optimize pathways, processes, risk stratification, population segmentation, granular targeted intervention. And finally, throughout, I'll be referencing the use of SNOMED CT and open standards to achieve excellence. So let's start with a definition as to what population health management is. It's a term that's used sort of very widely, and people don't always understand. I particularly like this definition because it actually focuses on a much broader approach, and it also references the technology required in order to do that. And it is very much about the understanding the needs of a population and how to plan targeted health interventions to improve the health and care of citizens. So I think it's also recognizing that this is about citizens, this is about whole populations, and not just about patients who are already within the system. This diagram that you've got here that describes the system capabilities, I sort of refer to as my wheel of fortune, and essentially it shows that it's an iterative approach. Starting with defining your population, which we classically do using population segmentation techniques. We will then do detailed analytics in order to be able to identify care gaps. And at this stage, we can actually employ both machine learning and artificial intelligence methodologies. That then leads us to the stratifying risks and actually identifying which segments of our population should have targeted interventions. And then we move into the face-to-face side of things. So we're talking about how to engage with patients, which generally happens best with clinicians, so that everybody feels empowered and involved in their care. And then it's about setting up the management of the care either at individual level or at a cohort level, place, region, or even nationally. And then, of course, we need to measure those outcomes, and we need to know what the baseline is before we then can go back around the loop in order to be able to see that we've made those improvements. If you want to know a bit more about it, I've created an animated version of this, which is on our YouTube channel, and the link is in the presentation. So over the last 3 years in the UK, we've basically had a national programme funded by NHS England called the Local Healthcare Record Exemplars. And it's really very much a bottom-up approach in terms of actually linking up systems of systems. So there were 5 Wave 1 exemplars, of which Yorkshire and Humber, which is a region of approximately 5.8 million citizens in the UK, with £12 billion annual health and social care investment. And you can see the other sort of facts and figures in terms of how many hospitals, local authorities, general practices, and integrated systems that we have. And you can see some of the challenges in terms of life expectancy, in terms of some of the the other comorbidities that exist. So our aim over the last sort of 2 to 3 years was essentially leverage technology that we have, in particular using interoperability standards such as HL7 and also SNOMED CT as the mandated clinical terminology in the UK, in order to basically create the Yorkshire Number Care Record. This will allow more time to be spent with people in the care of clinicians, provide improved connectivity and integration, allow better decision making and reduction in tests. And we're pleased to report that the Yorkshire Number Care Record was the first of the Wave 1 LICRAs, the others being Greater Manchester, One London, Thames Valley and Surrey and Wessex, to essentially deliver all of its key aims by April this year. So we're now live with our system. And essentially, we've got 3 particular sort of components, which are the integrated care record, the patient-held record, and the bit that I lead on, which is essentially the improved business intelligence and in order to do population health management. So as part of that capability, we've created the Yorkshire Number Data Ark, hence why I refer to this as sailing the high seas in the Data Ark. Okay, so the reason why I use the term Data Ark is because I've banned the word data lake, mainly because people can come along and take bucket loads of data out of a lake, but an ark gives you that security. It also references the fact that the animals come in 2 by 2. So we have structured data using clinical terminology such as SNOMED CT in order to allow better quality and linkage of data in order to do much broader longitudinal analysis. You can see from here that the component parts, it has all the security and cybersecurity, ISO compliant. We use the National De-Identification Tool Privatar, which is has been procured by NHS Digital. And we also have a system called the National Opt-Out, that if people don't want their data to be used for secondary purposes, they can actually express that wish, and we won't include that in any further analysis. We also wanted to include in this training and knowledge transfer and consultancy expertise, so that actually we built up a cohort of trained analysts, clinicians, and leaders across our region in order to be able to help their colleagues at their place, and also to do further population health management. It's a cloud-based platform. It's based on a Google Cloud platform, which means it can be accessed anytime, any place, anywhere. And it was research ready to support the digital innovation hubs in a scalable, secure, and affordable way. So this is essentially the architecture of what the Data Ark is, so making it seaworthy and ready to set sail. So it's a single platform for analytics, predictive modeling, machine learning, AI, visualization, and reporting, as I described. So our system of systems on the left-hand side is the component parts that are joined by FHIR resources in order to be able to access data from any system, regardless of who the vendor is, as long as we're using the appropriate interoperability standards. That component part of it is non-persistent data, but by the time it comes into the population health management platform, we persist the data through our integration services and into our data analytics data store. And you can see on the right-hand side the component parts in terms of those elements. We then, of course, have all the security and management, and we have a number of analytics products. And the 2 key focuses that we had for the initial deployment of this was around urgent care and around cancer. You can see the connection between what I do now as the Chief Data Officer for DataCan and the fact that we future-proofed the development of the Data Ark in order to make sure that actually it would provide those component sort of layers. And essentially at the top level, I've talked about the developers, so those NHS and social care staff who are actually the experts and do the developers. And then the consumers of this are essentially commissioners, health providers, clinicians, and health and social care workers. These are the types of outputs and visualizations that we had. This is the strategic analytics segmentation model at primary care network sort of level. And you can see the visualization, you can see how that is presented. And on this particular dashboard, we've sliced and diced it by deprivation, ethnicity, age, and there's an oncology component part, which is essentially around emergency admissions with cancer. This is another example of a large linked data set, which is our comprehensive patient record, which is approximately 450,000 patients over a 10-year period, based in Leeds, in Yorkshire, which is where I am at. I'm employed by the University of Leeds. And this was essentially a data quality assessment of that linked data set. And you can see this is 1.8 million records. So we're talking sort of pretty big data, very rich, very deep, and lots of component parts and very much a longitudinal record. So it's both primary and secondary care linked data, which makes it extremely powerful for this kind of analysis. So how does that fit into the health data research system? So health data research is a government-funded organisation. It's been in existence for a couple of years now. And last year there was a call put out to create 7 digital innovation hubs, of which we put in a bid as partners from Leeds, London, and Belfast, and were successful to become the health data research hub for cancer. So the hubs sit in the middle, as you can see on this particular diagram, and focus on improving health data. On the left-hand side, then you've essentially got the UK Data Health Research Alliance, and these are predominantly NHS organisations that have pledged to provide data in an appropriately anonymised way, and it's a combination of cohort data, registry data, trials data. And then on the right-hand side, these are surfaced through the Health Data Research Innovation Gateway, which is essentially the shop window where researchers, whether those are academic or commercial, can come and discover, link, access, analyze, and the data are appropriately de-identified for the users. The whole wrapper around this, of course, is it's very important that we have the trustworthy use of data, and we have a very engaged patient and public engagement program to make sure that we are delivering patient and public benefit from this. There are a number of tools, methods, and hubs that improve the health data. And on this slide, we can see what our strategic goals are. In 2021, we're focusing on the evaluation of data utility, and I've been leading on that with HDI UK Central, with CCIO Neil Spear and colleagues, in order to make sure that we have ways of developing data improvement and data approaches. The other hubs are named along the bottom, and if you want to know more about that, then you can actually go to the hduk.org.uk website. So DataCan in particular, so I've tried to put on this slide our vision in a page. I've talked about longitudinal records, and essentially our aim is to improve and link those for improved access, improved quality, and also to ensure fair value. It's very important when treating cancer patients that the patient is at the center here. And cancer is a very complex disease. It's also a genetic disease. We've mapped the whole genome, so essentially we can use molecular diagnostics in order to inform our treatment and approach. Clearly, there are huge amounts of clinical data, highly quality curated data and plain text, and using NLP techniques in order to do that. We can also have the application of machine learning and artificial intelligence to look at radiology and pathology. And you can see that the partners along the bottom here, so ourselves at the University of Leeds and Leeds Teaching Hospital are two of the founding partners. There is the UCL partners in London, and we have Queen's University Belfast, and Genomics England is another founding partner. And then because this is funded through the Industry Strategy Fund, our commercial partner is IQVIA. So let's just focus on SNOMED itself. So my previous job before I moved over to the university and took on my DataCan role was as CIO at Rotherham Foundation Trust. There we had implemented SNOMED CT throughout our EPR, Meditech, and we were using SNOMED CT for procedures and diagnostic recording throughout. The focus was very much on clinical ownership, and certainly it was successful because we actually had such strong clinical ownership from the top down, from the medical director all the way down to the nurses, AHPs, the junior doctors, and it was very well received and deployed throughout the whole of the trust. That, of course, helps in terms of improved data entry and clinical recording. And you can see on this slide some of the lookups. And the extension of the implementation of SNOMED across Yorkshire and Humber and also nationally really improves what we're trying to do to tackle those highways on the high seas and make sure that we reach our sort of goal. And it does help if there are certain champions, clinical champions who really get it, that can actually promote the use of clinical terminologies and actually work with their peers to improve the data quality. And finally, of course, we mustn't forget about the benefits for the patients. Some of the things that we were able to deliver within the trust was improved visualization of activity, which led to better patient care. You can see here that we were able to reduce the waiting times significantly, and also the number of missed appointments. So by having true digitization and actually being able to link records and be able to follow the full pathway, then you've got a much better way of tackling direct care and operational deployment, being able to improve secondary uses such as population health management, and also, of course, improvement for research and innovation. For the last sort of couple of minutes, I just want to sort of focus on the work that we've been doing during the COVID pandemic. We can't ignore the fact that actually, we have been thrown into this sort of situation, both regionally, nationally, and globally. And in particular, our focus from a DataCan perspective was to look at sort of what was the effect of COVID on cancer patients, whether those were already pre-diagnosed or whether they were patients who were not yet diagnosed with cancer, and what the sort of the delays and potentially the excess mortality was. So we did some very rapid data collection and analysis, and there's a few papers that we've published, and in particular this one estimating the excess mortality in people with cancer and multimorbidity, working with colleagues in London and UCL. It got very high sort of national coverage, and actually some of the figures were really quite frightening. So how did we come across this? What we started to notice, and you can see on the right-hand side of the slide here, that actually sort of around about sort of the end of March, we were starting to see a real drop-off in our urgent referrals, our 2-week wait, as we call it in the UK, so that those red flag indicators, and also the amount of patients that were turning up for outpatient attendances, mainly for chemotherapy. We normally see a dip at sort of Christmas and sometimes at Easter, but that recovers sort of within a week or two. And what we saw here was there was a huge drop off, and it didn't look like it was going to recover anytime soon. So really our sort of analysis was in order to be able to not only identify this, but as a call to action to our government, to NHS England, to say that cancer services needed to be resumed, and that actually we needed to find a way in order to make sure that that people weren't being inadvertently affected because of these changes. You can see on this particular sort of slide the overall sort of summary in terms of the sort of the presentation, in terms of screening, referrals, and emergency presentations, the diagnosis, the percentages here, and the treatment. And I'm pleased to say that actually the latest guidance that has come out from Simon Stevens, who's the Chief Executive of NHS England, in terms of our phase 3 recovery, has cancer services right as the top priority in terms of moving things forward. We've started to use some of our sort of Nightingale hospitals, our field hospitals, for cancer screening and creating non-hot sites where we can make sure that cancer services are back up and running. I won't go into too much detail on this particular one, but it just describes some of the large sort of data set, the 3.8 million caliber primary secondary care linked data set that we used. But the key thing that we actually highlighted was you need real time, and that's sort of daily, weekly data rather than monthly, annual sort of data, which we've classically used for epidemiology through cancer registration, because you need to be able to see the effects as they happen. This is the sort of the final slide that I'm showing, and you can see on the right hand side that the activity is starting to pick up. But what has happened to all of these people in this gap? We calculate that just in Leeds alone, we're missing about 4,000 missing referrals. And those patients will actually present at a much later stage, and unfortunately will probably have poorer outcomes and less chance of survival. So we have to be able to continue this, and as we move into a second wave, to make sure that we really know sort of what's happening. So we're extending our real-time network, we're leveraging the Data Ark, we're making sure that actually we've got the best data possible, and that we can actually help everybody as much as possible. So that's all I wanted to cover today. Thank you very much for listening. If you've got any questions now, then I'll be happy to take those. If not, then there are the links to both websites for DataCan and for the YHCR, and of course my email address if people want to follow up personally. Thank you very much for your time. I think I'll hand over to Susie.
Yes, thank you so much, Monica, for that excellent presentation. Can I please ask that attendees just give us a moment while we switch over from our pre-recorded content so that Monica can address your questions that you've been submitting live. Also, please note that the session will be available on the event platform for the next 3 months. Okay, hello, go ahead and enter your questions into the Q&A box, and we see a couple of them coming in right now. So from Linda Parisian, it says, "This is so great to see the real-time data and knowing that SNOMED CT is being used as a backbone terminology." Indeed, that is exciting. Monica, can you speak a little bit more to that? Because, yeah, I was wondering a little bit with regards to some of the current data that are encoded with the SNOMED CT.
Yeah, thanks very much, and nice to hear you, Linda, that you enjoyed the presentation. So Yeah, I think there's been sort of a step change, really. As you know, I've sort of been involved in the implementation of SNOMED for sort of many years, but I think particularly over the last sort of 18 months, where we've been looking at very much those integrated care records, so really joining up our system of systems. So rather than just focusing on hospital data, and particularly in the UK with the transition of our sort of primary care systems to using SNOMED CT, then actually the richness of the longitudinal record has become so much more accessible. Certainly in Yorkshire and Humber, you know, with our 74 different organisations and creating our sort of links, then actually our ability to be able to compare and contrast and actually sort of using SNOMED has massively sort of enhanced our insight, not just for direct care, but also for some of the population health management activities that we've been able to do, which of course then allowed us to do much more sort of in-depth and more rapid sort of analysis from a COVID perspective. So yeah, it's you know, we're not there yet, but I think the message is getting through. I think particularly in our emergency care, with the implementation of SNOMED as part of our emergency care data set, then actually that's also been a step change for colleagues in the UK to understand the true benefits for clinical terminologies, not just for direct care, but for analytics.
Another question from Karen Hodge. Fantastic presentation, thank you. What percentage of people opt out of secondary use of their data, and how does this impact on the interpretation of the overall data?
Yeah, no, that's a very interesting question, and not very many, actually. We sort of went live with the National Opt-out program, coincident with implementing GDPR in the UK and our Data Protection Act 2018. So you're talking less than 1%. Now that, you know, when you're looking at population-wide analytics, you know, so for 5.8 million people, then actually it doesn't have much effect at all. But the danger is, of course, that you might be missing particular cohorts of patients that actually, you know, have certain sort of characteristics. The analysis that's been done so far doesn't show particular sort of demographics that are opting out. So we're relatively confident that isn't having sort of too much of an effect. But the thing is, because it's an opt-out rather than an opt-in, because we have the NHS, then we're not having to consent everybody. So actually, there is that trust and as I talked about in the presentation, and that trustworthy component part. And I think just the final thing, particularly with some of the work that we've been doing with sort of cancer analytics, as I mentioned, we've got a really engaged sort of group of patients. People who have cancer become very engaged with their treatment and their illness, quite understandably so. And at all levels of governance, we actually have a patient representation from our steering committee all the way down to live co-design, sort of co-development of sort of data sets, and that also has a massive effect in terms of encouraging people to stay in the system rather than to opt out.
Excellent. I think we have time for one or two more questions. Seeing real-time data being used is very exciting. Fawad Rahman wants to know, what unique challenges did you face when processing and tagging real-time data?
Yeah, I mean, there's always that trade-off in terms of the sort of data quality versus the timeliness. But amazingly, I think a whole load of barriers have been sort of, you know, taken away as part of the sort of the COVID pandemic. So, you know, those classic computer says no kind of issues around sort of data privacy. Not that we've broken any data privacy sort of rules, but people have understood that actually you need real time at a national level. We've basically sort of got used to having data on a real-time basis. So frankly, there's been a good uptake, and we're keeping that momentum going, and with a determination that we're using real-time data wherever possible.
Thank you, Monica. We didn't get to all the questions, and they're really good ones coming in. Please feel free to ping Monica on the platform chat And if you have any additional questions for Snowman International, you know where to find us as well. Thank you all for joining us, and we'll see you in the next session.